Today we're going to be assessing the superior glenohumeral ligament and the inferior glenohumeral ligament with the sulcus sign at 0 degrees and also 90 degrees of shoulder abduction. The first sign, we're going to have the patient in short sitting. The clinician's going to be on the involved side. We're going to have one arm stabilizing the coracoid process and also the forearm stabilizing the scapula. The other arm is going to be relaxed, and we're going to do a traction force. If there is any pain, clunk, or any hollowing between the acromion process and the head of the humerus, then you would have a positive sign for the sulcus. And now we're going to be testing the inferior glenohumeral ligament with the sulcus sign at 90 degrees. We're going to be doing an inferior force of the arm to check for it, and the signs will be similar. Assessing the anterior humeral ligament laxity and also the posterior humeral ligament capsule and its laxity with the anterior load and shift and the posterior load and shift. Typically these are done bilaterally. If you notice that equal on both sides, then there shouldn't be any clinical value. For the anterior load and shift, we're going to have the patient in short sitting. Condition's going to be on the tested side. One hand's going to be at the coracoid process. Forearm's going to be stabilizing at the scapula. Other hand's going to be grabbing the proximal humeral head. And we're going to be doing an anterior force of the humeral head to look for anterior humeral ligament laxity with positive signs of painful click, excessive translation, instability, which would indicate an anterior humeral ligament laxity. For posterior load and shift, we would just do the opposite. Same signs with the posterior load. That would be checking the posterior humeral ligament, posterior capsule. Today we're going to be assessing if there is a slap lesion of the shoulder. The patient's going to be in short sitting. Clinician's going to be on the tested side. We're going to be stabilizing at the coracoid process, forearm at the scapula. Other hand's going to be at the distal elbow with the shoulder abducted to 45 degrees. And we're going to be doing a circumduction motion and adding a loading axial force into the glenoid cavity. And if there is any pain clicking or pseudo-locking, that would indicate that the humeral head is catching on the superior labrum secondary to a slap lesion. We're going to be assessing for a slap lesion with the anterior and posterior slide. Patient's going to be in short sitting. The examiner is going to be on the involved side with one arm stabilizing the coracoid process, forearm stabilizing the scapula. The other arm is going to be stabilizing at proximal radial ulnar joint. Checking for the anterior slap with extension of the humerus. And if there's any pain, then there may be a lesion at the anterior slap. If we bring the humerus forward into flexion, compress into the glenoid cavity, and if there is pain, then there may be a posterior slap lesion. We're going to be assessing the long head of the biceps tendon with the speed sign. The patient's going to be in short sitting, glenohumeral joint in anatomical position, elbow extended, and forearm supinated. The position of the examiner is going to be on the affected side, and we're going to ask the patient to flex to 90 degrees of shoulder flexion and have them hold it there. And I'm going to be pressing down. And if there is any pain in the bicipital groove, then that's positive for long head bicep tendonitis. We're going to be doing the gold standard for the slap lesion. We can also assess the AC joint with the O'Brien's test. The position of the patient is short sitting. Position of the examiner is on the involved side. We're going to have the patient horizontally adduct his shoulder and internally rotate his arm while we apply a downward force to the humerus, causing them to resist that motion. And if there is pain, that'll be positive for part one. We're going to have them supinate their arm. We repeat the process, and if the pain resolves, then that would be a positive sign for the O'Brien's. If there is pain in the superior shoulder, it's indicative of a lesion at the AC joint. We're going to be testing the transverse humeral ligament today and the bicipital tendon for inflammation with the Yergason test. The patient's going to be seated, glenohumeral joint in anatomical position, elbow flexed to 90 degrees, forearm pronated. The position of the examiner is lateral to the patient on the involved side. Forearm stabilized proximal to the wrist. Patient flexes elbow against resistance while the examiner resists the patient's moving into supination. So this motion. And so I'm gonna have you go into supination. Bring your palm up for me. All right. If there is pain with snapping, then there may be a pathology with the transverse humeral ligament. If there's pain without snapping, then it's indicative of bicipital tendinitis. We're going to be assessing AC joint degeneration and acromioclavicular and coracoclavicular ligaments with the acromioclavicular anterior and posterior shear test. Patient's going to be in short sitting, arm in lap, position of the examiner standing on the involved side. Evaluative procedure, hands going to be cupped over the anterior and lateral clavicle and the acromion and posterior acromion. The examiner is going to squeeze the hands together, compressing the AC joint. Positive tests would include pain to the AC joint or excursion of the clavicle over the acromion process. And that would indicate an AC acromioclavicular degenerative joint disease or damage to the acromioclavicular or coracoclavicular ligament pathology. We're going to be assessing impingement of the supraspinatus or long head bicep tendon between the greater tuberosity and the inferior side of the acromion process and coracoacromial ligament with the Neers impingement test. Patient's going to be short sitting, shoulder, elbow, and wrist are in an anatomical position. Position of the examiner is slightly lateral and forward on the involved side. Patient's shoulder and scapula are stabilized on the posterior aspect. The examiner grips the patient's arm at the elbow joint. Elbow extended and then passively flex until we reach the end of motion. And if there's pain with the motion, especially near the end, then there's impingement of the supraspinatus or long head bicep tendon. We're going to be assessing for impingement of the supraspinatus with the Hawkins and Kennedy impingement test. Patient's going to be in short sitting, arm in the scapular plane, shoulders position 90 degrees of flexion, forearm neutral. The examiner is going to be lateral to the involved side. With this evaluation, we're going to be internally rotating. If there's pain with the motion, especially at the end, this would be a positive sign for impingement of the supraspinatus between the greater tuberosity and the inferior side of the acromion process. We're going to be assessing the subscapularis, long head bicep tendon, and supraspinatus with the coracoid impingement test. The patient's going to be in short sitting, shoulder and elbow position in 90 degrees, flexion in sagittal plane. Clinician's going to be in front of the patient on the involved side. We're going to push down at the dorsal wrist, causing internal rotation at the shoulder. And if there is anterior pain with motion, then this would implicate a subscapularis medially and long head bicep tendon medially, while supraspinatus impingement produces lateral pain. We're going to be assessing the subscapularis or long head bicep tendon, supraspinatus, AC joint, and a few other shoulder muscles. The patient's going to be in short sitting, examiner is going to be on the involved side. We're going to have the patient move the involved shoulder into horizontal adduction with overpressure. Localization of pain is noted. Pain experienced with the overpressure to anterior, indicative of subscapularis or long head bicep tendon. Lateral pain may indicate supraspinatus. Superior pain is indicative of AC joint. Posterior pain is indicative of infraspinatus teres minor or posterior capsule. We're going to be assessing a rotator cuff with the drop arm 1 and 2 test today. We're going to have the patient in short sitting, involved shoulder passively raised to 90 degrees of abduction, palms facing down. The clinician is going to be standing on the involved side. One hand is held beneath the patient's arm just in case the arm drops suddenly. With this test, we're going to be tapping up here to make sure that if the arm drop, it indicates a full thickness rotator cuff tear. And for part 2, they're going to bring their arm up all the way to the top. Externally rotate, make sure there is an impingement here. We're gonna have them slowly bring it down. And if it drops, yes, that's a positive sign for full thickness rotator cuff tear. We're going to be assessing the infraspinatus and supraspinatus with the external rotation lag sign. Patient's going to be in short sitting. Elbow is passively flexed to 90 degrees. Shoulder is held at 20 degrees of flexion in scaption. We're going to externally rotate the shoulder and then bring it back 5 degrees to avoid elastic recoil in the shoulder. For part 1 of the test, we're going to let go at the wrist, and if there is lag there, then it would indicate a weak or pathology with the infraspinatus. If we let go with at the elbow and their arm drops, then that would indicate a pathology at the supraspinatus. We're going to be assessing the infraspinatus with the drop sign. Patient's going to be in short sitting. Elbow is passively flexed to 90 degrees. Shoulder is held at 90 degrees of flexion in scaption. The clinician is going to be on the involved side, and we're going to be letting go at the wrist. If they cannot maintain that position, then it's a positive sign for dysfunction or pathology at the infraspinatus. We're going to be assessing the subscapularis. The patient's going to be short sitting. Elbow is passively flexed to 90 degrees. Shoulder is held at 20 degrees of extension. The examiner holds the affected arm in maximum internal rotation. So I'm going to bring it out, make sure to avoid bringing the whole arm back and just bringing the hand out for internal rotation. If they're not able to hold that position, that would indicate a partial tear at the subscapularis. If their whole arm dropped, that is a full tear of the subscapularis. We're going to be assessing the anterior capsule and glenoid labrum, as well as the other structures of the shoulder, with the apprehension, as well as the Jobe subluxation and relocation. We're going to have the patient in supine. Glenohumeral joint is abducted to 90 degrees. Elbow flexed to 90 degrees. Position of the examiner is beside the patient on the involved side. Passively externally rotates the glenohumeral joint by slowly applying pressure to the forearm. The patient displays apprehension that the shoulder may dislocate, and that would indicate a pathology at the anterior capsule or the glenoid labrum may be compromised. We're going to continue on with the Jobe subluxation and relocation. At this point, the patient's elbow rests on the examiner's knee, and the examiner supports the wrist with one hand. The examiner grasps the posterior humeral head with the other hand. We're going to be providing an anterior force. If there is pain on the anterior side, there is microinstability. And if there is pain on the posterior side, then there may be internal impingement syndrome. These are only positive if I do part 2 of the test, which is a posterior force into the glenohumeral joint, and the symptoms and pain resolves. We're going to be assessing the posterior instability of the shoulder with the posterior glide at 0 degrees and 90 degrees. We're going to have the patient in supine, shoulder position to 90 degrees of forward flexion, relaxed into internal rotation with elbow at 90 degrees. The examiner is on the side of the involved side. In this procedure, we're going to be palpating posterior glenohumeral joint to feel for the translation of the humeral head. We're going to be applying a posterior force. If there is pain, apprehension, clicking, or instability, there may be posterior instability of the shoulder. We're going to continue on to posterior glide at 90 degrees. Similar to the other tests, but in this one, we have the shoulder more of a abducted position. We're going to feel for the same things. We're going to be doing a posterior force into the humeral head, and if there is pain, apprehension, and instability, there may be posterior instability of the shoulder. We're going to be assessing for recurrent posterior instability. with the jerk test. The patient's going to be in supine shoulder position to 90 degrees of forward flexion. Relax the internal rotation, 90 degrees of flexion. And position the examiner on the involved side. Examiner grasps the elbow with one hand while the other hand is behind the shoulder across the posterior humerus. There will be a positive result as we move the humerus into adduction. If there's a jerk sensation, which occurs when the humeral head subluxes over the posterior labrum and the back of the glenoid fossa. A similar jerk can be felt when the humeral head relocates itself back into the glenoid fossa. We're going to be assessing the labrum at the shoulder with the Clunk 1, Clunk 2, and crank tests. We're going to have the patient lying in supine. Position of the examiner is beside, near the head of the patient on the involved side. The examiner's hands grasp the proximal humerus and have the patient's forearm wedged between our body and our forearm. We're going to place our hands close to the humeral head and circumduct to try to aggravate the joint. If there's plain clunk pseudo-locking, then that may imply an anterior inferior torn labrum. We're going to proceed to the Clunk 2, switching over using the proximal hand as a fulcrum and abducting, slightly abducting and ratcheting up to try to elicit any pain, clunking, or pseudo-locking. This would implicate a labral lesion depending on the area the labrum provoked. Lastly, we're going to have the arm abducted 160 degrees in the scapular plane with the elbow at 90 degrees flexion. We're going to internally and externally rotate the arm, the humeral head, and if there's pain during internal or external rotation or reproduction of symptoms, usually pain, catching, or pseudo-locking felt by the patient during athletic or work activities, then there may be a glenoid labral tear. Thank you.